Huh?
Doorways. Today we'll be talking about physiological changes in pregnancy. Hope this class was previously also was taken by another senior, but now we will repeat again physiological changes in pregnancy. So it's on screen. So what is meaning of physiological changes in pregnancy? That means these are some changes the mother adapts during pregnancy due to several factors. So why these changes occurs? Because of the growth of the fetus inside the uterus. So there are many changes occurring in the mother during the pregnancy. So the changes occurs in the genital organs. There are some skin changes, changes in the cardiovascular system, some hematological changes, systemic changes, metabolic changes, endocrine system. So look at this figure. When an antenatal mother comes to you, when an antenatal mother comes to the clinic for a regular checkup, so these are the things you will be examining. So what all you will be examining is height and weight. You will be taking care of the heart and lungs. You have to examine the breast and nipples. Then during investigation, you have to examine the legs for any edema. Then you have to examine the abdomen. Then the other investigations, you have to check her blood pressure, her pulse rate. Then you have to do all these investigations. So once you conduct this examination, and you should know whether what you have examined is normal for the patient or anything abnormal. So that is why this class is. If you have observed some abnormal values during your examination, then you should be able to assess whether the abnormal values are normal or abnormal for the pregnant female. That is why you have to know the physiological changes or adaptations that occur in a pregnant mother uh, in the mother during pregnancy. So the major adaptations in maternal anatomy, physiology, and metabolism are required for successful pregnancy. So by the previous, in the previous slide, you have seen during examination, almost every organ system is affected. Understanding these changes helps to distinguish normal physiology of pregnancy from pathological disease states. So the normal changes, the normal changes, the normal physiological changes and the normal values in pregnancy vary from the non-pregnant states. So physiological changes are normal for pregnancy, but any abnormal values beyond that indicate some pathological states in the pregnancy. So you can divide these changes in pregnancy into 3 areas. It can happen anatomical changes, physiological changes, and biomechanical changes, or biochemical changes also. So what are the anatomical changes and where all do they happen? So these occur in the genital organs mainly. So genital organs means the vulva, vagina, and the uterus. So look at the figure which shows indicates the size of the uterus in different trimesters. So growing of the abdomen in a pregnant woman is due to the growth of the fetus and the growing size of the uterus. So first we'll go to the changes occurring in the vulva. So what happens in the vulva? So it becomes edematous and more vascular. Sometimes there'll be appearance of varicosities. These are varicosities appearing on the vulva. And the labia minora are more pigmented and hypertrophied during pregnancy. So what is the changes occurring in the vagina? Vaginal walls are hypertrophied, edematous, and they become more vascular. So increased blood supply of the venous plexus surrounding the walls of the vagina gives a bluish discoloration. Look at this bluish discoloration. Bluish discoloration of the vagina. This is because of increased blood supply in the walls. It is called Jacquemus sign. Sometimes the length of the anterior vaginal wall also is increased. What happens to the secretions? The secretions are also increased. They become more. They are thin and curdy and white. And this is due to exfoliated cells and bacteria. The pH becomes acidic due to more conversion of glycogen to lactic acid because of high estrogen levels. The acidic pH prevents multiplication of pathogenic organisms. Then changes in the uterus. What happens to the uterus? There is enormous growth of the uterus during pregnancy. So the pregnant uterus at term weighs 900 to 1000 grams. Whereas non-pregnant uterus, how much does it weigh? Around 80 grams. And measures around 35 centimeters in length. How much a non-pregnant uterus weighs? Around measures around 7 to 9 centimeters in length. The capacity is increased by 500 to 1000 times. These changes occurs to accommodate the growth of the fetus. Changes occurs in all parts of the uterus. So we'll learn what all the changes that occurs in the body of the uterus, in the isthmus part of the uterus, and in the cervical part of the uterus. So the changes that occur in the body of the uterus. So there is increase in growth and enlargement of the body of the uterus. So what causes the enlargement? Sometimes this enlargement is not symmetrical one. The fundus enlarges more than the body. So it is evident by the lower down attachment of the round ligaments or insertion of the uterines of the fallopian tubes at term. So how does this enlargement occurs? There is change in the muscle. It because of hypertrophy, hyperplasia, and stretching of the muscle fibers, the enlargement occurs. These occur under the influence of the hormones estrogen and progesterone. Stretching of muscle fiber further elongate beyond 20 weeks due to distension of the growing fetus. The wall becomes thinner and at term measures about 1.5 centimeters or less. And what is the consistency? The consistency feels soft and elastic in contrast to firm feel in non-gravid uterus. Then in the body of the uterus, what happens to the vascular system? There is marked spiraling of the arteries reaching a maximum at 20 weeks. Then the spiraling arteries, they straighten out. Blood flow also increases by 8-fold at 20 weeks of pregnancy. There is vasodilatation is mainly due to the hormones, progesterone and estrogen. Veins become dilated and are valveless. Numerous lymphatic channels open up. So what is the shape of a uterus? Non-pregnant piriform shape is maintained in early months. It becomes globular at 12 weeks. As the uterus enlarges, the shape becomes more piriform or ovoid by 28 weeks and then changes to spherical beyond 36th week. So when you examine the abdomen, when you look at the shape of the abdomen and when you palpate, you will know approximately how many weeks the woman is pregnant. Position, normally anteverted position is exaggerated up to 8 weeks. Later on, it becomes erect and the long axis of the uterus conforms more or less to the axis of the inlet. What happens at term? Because of lax abdominal wall, there is tendency of anteversion. But in primary, with good tone of the abdomen, it is held firmly against the maternal spine. So what happens in multipara? There will be tendency because of the lax abdominal wall, there is tendency of anteversion. But in primaries, where the tone is very good and the abdominal muscles, it stands erect and it firmly rests on the maternal spine. So look at the shapes. Non-pregnant, it is piriform. At 12 weeks, it is globular. Just I have put some fruits to compare a 12 weeks uterus. It looks like this. A 28 weeks uterus takes piriform shape. Again at 36 weeks and at term, it is spherical or globular. And these are the false contractions or the false pain because it's called Braxton Hicks contraction. These are irregular, infrequent, and spasmodic and painless without effect on the dilatation of the cervix. What happens to the endometrium? The secretory activity of the endometrium increases. Then the isthmus. What is this isthmus? These are important structural and functional changes in the isthmus during pregnancy. During the first trimester, what happens? The isthmus hypertrophies and elongates it about 3 times its original length. It becomes softer. Beyond 12 weeks, it progressively unfolds and from above downwards until it is incorporated into the uterine cavity. The circularly arranged muscle fibers in this region function as a sphincter in early pregnancy and thence help to retain the fetus within the uterus. Incompetency of sphincteric action leads to mid-trimester abortions. So, what happens? So, at 8 weeks, this is the anatomical internal os, and this is the histological internal. This is the area of the isthmus. So, at 8 weeks, it is almost closed. At 12 weeks, it slowly elongates. And later at 16 weeks, it opens up above downwards and accommodates into the uterine cavity. This forms the, at term, this forms the lower segment of the uterus. So, there is so much importance for the isthmus. What happens to the cervix? There will be hypertrophy and hyperplasia of the elastic and connective tissues. Vascularity is increased. There is softening of the cervix, which is called Goodell's sign. Squamous cells also become hyperactive. Mucosal changes simulate basal cell hyperplasia or SIN. Secretion becomes more and tenacious, which is called. So during pregnancy, patient complains of lot of vaginal secretions. So this is normal. This is physiological leukorrhea of pregnancy. And the cervix also becomes bulky. Why the cervix? Because of hypertrophy and hyperplasia of the connective tissues. So if a pregnant patient complains of more vaginal discharges, it is physiological leukorrhea of pregnancy. So look at this. With normal cervix, it looks like this. Cervix is bulky and hypertrophic. So this is columnar junction. This is the extension of the columnar epithelium and more dilated vessels cervix becomes more vascular. This is the mucus plug in the cervix. What happens to the fallopian tube? Total length is increased because of vascularity. Tube becomes congested. Muscles undergo hypertrophy. Ovary. So growth and function of the corpus luteum reaches its maximum at 8th week. There is colloid degeneration at 12th week, which later becomes calcified at term. The hormones, estrogen and progesterone of the corpus luteum maintain the environment of the growing ovum, control the formation and maintenance of decidua in pregnancy, and it inhibits the ripening of the rest of the follicles. So that is the changes in the uterus. Now, some changes are occurring in the breast also during pregnancy. In pregnancy, there is increase in the size of the breasts. There is marked hypertrophy and proliferation of the ducts. Under the influence of the hormones, estrogen and vascularity is also increased. The nipples become more erectile and deeply pigmented and larger. The sebaceous glands 5 to 15 become hypertrophied and are called Montgomery tubercles. Outer zone of less marked and irregular pigmented area appears in the second trimester and is called secondary areola. Some secretions can be squeezed out of the breast in the antenatal period, which is colostrum at about 12th week. So breast becomes sore, darker and larger nipples, the size increases, growing breasts, and there is after 12 weeks there is some leaking of colostrum and discharge from the. These are the common breast changes that occur during pregnancy. So what are the skin changes? On the face, it is called the pigmentation. It is all about pigmentation. The face, there is some pigmentation are occurring around the cheek, forehead, and around the eyes. It is called colosma gravidarum or pregnancy mask. Sometimes it is diffuse or sometimes it is patchy, and they disappear spontaneously after delivery. So next, the skin changes on the abdomen. There is a dark brownish black pigmented area in the midline stretching from the xiphisternum to the symphysis pubis. This is called linea nigra. And the slightly depressed linear marks with varying length and breadth found in pregnancy around the umbilicus is called stria gravidarum. There is some you can see some changes like vascular changes like palmar erythema and vascular spider. So spider angioma and palmar erythema under the influence of hormones. Look at this. This is striate gravidarum. This is the line, the midline extending from the xiphisternum to the symphysis pubis called linea nigra. This is the pigmentation around the eye, cheek, nose, and forehead, which is called colosma. And this is spider angioma, and this is palmar erythema under the influence of hormones like estrogen. Look at the spider angioma. So, weight. There is the increase in weight is due to weight changes occur during pregnancy. The increase in weight is due to the increased growth of the uterine muscles, connective tissue, and vascular changes. So how the weight gain occurs? In early weeks, the patient may lose some weight because of nausea and vomiting. But in the subsequently, there is slow weight gain, is progressive and it lasts for 1 or 2 weeks, and later on it remains static. So what is the total weight gain during the course of a singleton pregnancy is 11 kgs for a healthy woman. Distributed to 1 kg in the first trimester, 5 kg in each second and third trimester. So the total weight gain at term is distributed approximately as this. So reproductive weight gain is around 6 kgs. So fetus it is 3.3 kg, placenta it's 0.6 kg, liquor is 0.8 kg, uterus and 0.9 kg and breast is around 0.4 kg. Accumulation is 3.5 kg. The blood volume increases around 1.3 kg and increase in all these contribute to the total 11 kgs. To 11 to 12 kgs. So what is the importance of weight checking? Why you need to check weight? So when there is a problem, when there is rapid increase in the weight or there is decrease in the weight. So both these give us important, these are important signs of something happening in the system. So what is it? If there is rapid weight of more than 0.1, 0.5 kgs, if it is the weight gain is more than or more than 2 kgs a month may suggest early signs of preeclampsia. Then stationary or falling weight is also a problem. That means the fetus is not growing properly inside or there is a dead fetus and not growing anymore. So stationary falling weight. So that is the importance of weight checking. They suggest intrauterine growth retardation or intrauterine death of the fetus. Ideally, Weight gain should depend on pre-pregnancy body mass index level. Weight gain for a woman with normal BMI 20 to 26 is 11 to 16 kgs. But in an obese woman, more than BMI is more than should not gain more than 7 kgs, whereas underweight women less than 19 may be allowed to gain up to 18 kgs. So look at this. So pre-pregnancy BMI is 18.5 to 24.9. So it allows a weight gain up to 16 kgs. So it is 11 to 16 kgs at term. Then if it is less, then they can go up to 18. Upper limit is up to 18 kgs. If the BMI is more, around 29, they are not allowed to gain weight more than 7 to 8 kgs. Lower limit is 8 kgs. What happens to the body? Water metabolism. Water retained at term is about 6.5 liters. So the water content of fetus placenta amnion amounts to 3.5 liters. Pregnancy is a state of hypervolemia. There is active retention of sodium and potassium and water. The causes for retention and volume overload are changes in the osmoregulation, increased estrogen and progesterone, increased renin-angiotensin activity, increased aldosterone dioxide, controlled by arginine vasopressin from the posterior pituitary and atrial natriuretic peptide. Changes occurring in the hematological changes. Blood volume. Due to increased vascularity of the enlarging uterus, blood volume is markedly raised during pregnancy. The blood volume starts to increase from about 6th week and expands rapidly thereafter to a maximum of 40 to 50% above the non-pregnant level at 30 to 32 weeks. Plasma volume. It starts to increase by 6 weeks. Starts to increase by 6 weeks, rate of increase almost parallels to that of blood volume, reach to an extent of 50%. So total plasma volume increases to the extent of 1.25 liters. What happened to RBC mass and hemoglobin? The RBC mass is increased to the extent of 20 to 30%. Increased demand of oxygen transport during pregnancy, disproportionate increase in the plasma to 50% and RBC volume around 20 causes hemodilution. So HB falls about 2 grams from the non-pregnant level value. What happens to the leukocytes and the immune system? Neutrophilic leukocytosis occurs to the extent of 8,000 per meter squared and to even 20,000 in cubic meters in labor. The increase may be due to rise of levels of estrogen and cortisol. The major change in the immune system is the modulation away from cell-mediated cytotoxic immune response towards increased humoral and innate immune response. So principal blood changes. Look at this. In non-pregnant state, the blood volume is around 4,000. Then at pregnancy near times 5,500, total increment is 1,500. The change is 30 to 40%. Then plasma volume. Non-pregnant 2,500, pregnancy 3,000 and 1,250. 40 to 50% is increased. Red cell mass is hemoglobin 18 to 20%. In hematocrit, it is diminished. Total proteins. What happens to total proteins? Total plasma weight increases from normal 180 grams non-pregnant to 230 grams at term. Due to hemodilution, the plasma protein concentration falls from 7 grams to 6 grams. This results in diminished viscosity of the blood and reduced osmotic tension. So this is the plasma protein changes during pregnancy. Total proteins in non-pregnant is 180. Pregnancy near term is 230. It is increased. What happens to plasma protein? Because of hemodilution. Then albumin 4.8 it's decreased. Globulin is also decreased. And albumin globulin value is also decreased. So these are the normal changes that occur in pregnancy. So when you look at these values, they are normal for the pregnancy. What happens to the blood coagulation? So as we know, pregnancy is a hypercoagulable state. Fibrinogen level is raised from by 50% to 200 to 400 milligrams per deciliter in non-pregnant to 300 is in pregnancy. So non-pregnant 1,60,000 to 2 lakhs. It is static or 15% reduction in count. Fibrinogen 200 to 300 to 6. Fibrinolytic activity is depressed. A clotting time unaffected. ESR is 10 mm, it's 40 mm in the marked increase in 4 times. Now we go to the cardiovascular system. The anatomical changes, the heart, particularly the left ventricular hypertrophies, leading to enlargement of the heart. The growing uterus pushes the heart upward and to the left. During pregnancy, the heart rate and stroke volume increase due to increased blood volume and oxygen requirement of the maternal tissues and growing fetus. So this is non-pregnant and pregnant. There's 40% increase, stroke volume by 27%, heart rate by plus 17%. There is 15 beats per minute heart rate. Then venous pressure is also increased. Colloid osmotic pressure is negative. Systemic vascular resistance decreases. Pulmonary vascular resistance also decreases. What happens to the cardiac output? The cardiac output starts to increase from 5th week of pregnancy, reaches its peak by 40 to 50% at about 30 to 34 weeks. The increase in cardiac output is chiefly affected by increase in the stroke volume and increase in pulse rate to about 15 beats per minute. Then the cardiac output is lowest in sitting or supine position and highest in the right or left lateral or knee chest position. The mean arterial pressure rises. So from the 5th or 6th week, it starts raising slowly. The stroke volume, heart rate, the blood volume, and the cardiac output. Systemic vascular resistance is decreases due to smooth muscle relaxing effect of progesterone, nitric oxide, prostaglandins, and atrial natriuretic peptide. The maternal BP is equal to cardiac output into systemic vascular resistance. BP, there is overall decrease in diastolic blood pressure and mean arterial pressure by 5 to 10 mm mercury. The decrease in blood pressure parallels that of systemic vascular resistance. So what happens during the mid-trimester? Changes in blood pressure may occur causing fainting like episodes. In later pregnancy, hypertension may occur in 10% of women in unsupported supine position. This is termed as supine hypotensive. Why this occurs is because of the pressure of the gravid uterus compresses the vena cava, reducing the venous rhythm. The cardiac output is reduced by 25 to 30% and the blood pressure falls by 10 to 15%. venous pressure. What happens? Antecubital venous pressure remains unaffected. Femoral venous pressure is markedly raised. It is due to pressure exerted by the gravid uterus on the common iliac veins. It is femoral venous pressure is raised by from 8 to 10 centimeters to 25 centimeters to about 20, 25 centimeters in pregnancy in lying down position and to 80 to 100 centimeters of water in standing position. This is the reason for physiological edema of pregnancy. So, this physiological edema of pregnancy subsides by rest alone. Distensibility and stagnation of blood in the venous system explains the development of edema, varicose veins, piles, and DVT. So, because of the pressure of the enlarging uterus on the pelvic veins, there is varicose veins and edema of the pit. This physiological edema, gets relieved with the rest. So, what is supine hypotension syndrome? Or postural hypotension we noticed in a pregnant woman. What happens? The gravid uterus produces a compression effect on the inferior vena cava when the patient is in supine position. This results in opening of a collateral circulation by means of paravertebral and azygous veins. When the collateral circulation fails to open up, which occurs in 10% of the cases, the venous return of the heart may be seriously curtailed, which results in production of hypotension, tachycardia, and syncope. The normal pressure is quickly restored by turning the patient to the lateral position. So, in the supine position, when the gravid uterus compresses the vena cava, then the venous return is reduced and cardiac output decreases and there is hypotension. What happens to the uterine, to the blood flow? Uterine blood flow is increased from 50 ml per minute in non-pregnant to 750 ml near term. Pulmonary blood flow is 6000 ml per minute to 2500 ml per minute. And renal blood flow 800 ml. It increases by 400 ml per minute at 16th week. Heat sensations with sweating or stuffy nose can be explained by the increased blood flow. Metabolic changes. General metabolic changes. Total metabolism is increased due to the needs of the growing fetus and the uterus. The basal metabolic rate is increased to about 30% higher than the average for the non-pregnant woman. What happens here to the protein metabolism? It's a positive nitrogenous balance throughout pregnancy. At term, fetus and placenta contains about 500 grams of protein and maternal gain is about 500 grams, chiefly distributed in the uterus, breast and maternal blood. The breaking down of amino acids to urea is suppressed. The blood urea level falls to 15 to 20 milligrams. Amino acids are actively transported across the placenta to the fetus. Pregnancy is an anabolic state. Carbohydrate metabolism. Insulin secretion is increased in response to glucose and amino acids. There is hyperplasia and hypertrophy of the beta cells of pancreas. Sensitivity of insulin receptors is decreased. Plasma insulin level is increased due to estrogen, progesterone, and human plasma cortisol, prolactin, and increased tissue resistance. This mechanism ensures continuous supply of glucose to the fetus. Plasma glucagon levels remains unchanged. Fat metabolism, average 3 kg to 4 kg of fat is stored during pregnancy, mostly in the abdominal wall, breasts, hips, and thighs. plasma lipids and lipoproteins increase appreciably during the later half of due to increased estrogen, progesterone, HPL, and leptin levels. HDL levels increase by 15%. LDL is utilized for placental steroid synthesis and hyperlipidemia of normal pregnancy. This hyperlipidemia of normal is not atherogenic. That means it doesn't clot the vessels. Leptin, a peptide hormone secreted by the adipose tissue and placenta, it regulates the body fat metabolism. So, total lipids in non-pregnant state is 650. In pregnancy near term, it is 50% increased. LDL is 180, pregnancy 260, and 40%. HDL is plus 15, triglycerides also. So there is a hyperlipidemic-like state in the pregnancy. What happens to iron metabolism? It is absorbed in the ferrous form from duodenum and jejunum and is released into circulation as transferrin. About 10% of the ingested iron is absorbed. So total iron requirement in pregnancy is approximately 1 gram or 1000 milligrams. This is distributed in the fetus and placenta 300, expanded red cell mass 400, 350 and 1 ml contain 1.1 milligrams of iron. The amount of iron absorbed from the diet and that mobilized is inadequate to meet the. In the absence of iron supplementation, there is drop in hemoglobin, serum iron, serum ferritin concentration at term. Thus, pregnancy is inevitable iron deficiency state. So, non-pregnant and second half of pregnancy. All the values are almost decreased. So, changes occurring in the respiratory system. Shape of the chest and circumference increases in pregnancy by 6 centimeters. There is increase in oxygen consumption which is caused by increased metabolic needs of the mother and fetus. The mucosa of the nasopharynx becomes hyperemic and edematous. There is a hyperventilation state in pregnancy leading to increased tidal volume. Woman feels shortness of breath. Pregnancy is a state of respiratory alkalosis. So there is the flaring of the rib cage. The subcostal angle increases by 60-80 decibel in pregnancy and now shows elevated diaphragm and increased chances of flaring out of ribs and the subcostal by 5 to 7 centimeters circumference. So, in the non-pregnant, respiratory rate is unaffected. The vital capacity is almost unaltered. Tidal volume is increased by 40. The residual volume is decreased by 20%. Total lung capacity also decreases by 5%. What are the changes that occur in the urinary system in pregnancy? In the kidney, there is dilatation of the ureter, renal pelvis and calyces. The kidney enlarged in length by 1 centimeter. Renal plasma flow is increased by 50 to 75% maximum by the 16 weeks and is maintained until 34 weeks. Thereafter, it falls by 25%. GFR glomerular filtration rate is increased by 50% all throughout the pregnancy. The ureters become atonic due to high progesterone level. Dilatation above the pelvic rim stasis is marked in the right side, especially in a primary. Changes that occur in the urinary bladder. There is congestion and hypertrophy of the bladder wall. In late pregnancy, becomes the bladder mucosa becomes more edematous due to venous and the lymphatic system. Increased frequency is noticed at 6 to 8 weeks of pregnancy, which subsides after 12 weeks due to resetting of osmoregulation. In late pregnancy, frequency once more reappears due to pressure on the bladder as the presenting part descends down the pelvis. Sometimes there is stress incontinence may be observed in late pregnancy due to urethral sphincter weakness. So, early pregnancy, the uterus is but within the pelvis, compressing the bladder. So, there is frequency of, so look at this. It is the growing uterus cause compression of the bladder. So, there is increase. In mid-pregnancy, the uterus is lifted out of the pelvis. Then the maturation comes to normal. It is away from the again. At term, the head starts descending, the fetus head into the pelvis, again compressing the bladder, which leads to frequency of urination. So what happens to the alimentary system? The GIT, the gums become congested and spongy and may bleed to touch. Muscle tone and motility of the entire GI tract are diminished due to high progesterone level. Cardiac sphincter is relaxed and regurgitation of acid gastric content in the esophagus may produce chemical esophagitis and heartburn. There is diminished gastric secretion and delayed emptying time of the tonicity of the gut leads to constipation. So they are bleeding gums. So relaxation of the sphincter, there is regurgitation and harm. Gas and diminished gastric results in more efficient pulping of the food, may cause nausea. There is reduced motility in small increases time of absorption. Reduced motility in the large and increased time for water absorption, but also tends to induce constipation. Reduces the frequent. The liver functions are depressed with exception of alkaline phosphatase. The other liver function tests, serum are unchanged. There is mild cholestasis because of the estrogen effect. There's marked atonicity of the gallbladder because of progesterone effect. Together with the high blood cholesterol level during favor stone formation. Nervous system, temperamental changes are found during pregnancy and in puerperium. Nausea, vomiting, mental irritability, and sleepiness are probably due to some psychological background. Postpartum blues, depression may develop in a susceptible compression of the median nerve under the wrist joint. Flexor retinum cause pain and paresthesias in the hand and arm. This is called the carpal tunnel syndrome. Similarly, some paresthesias and sensory loss over the anterolateral aspect of the thigh may occur. It is due to compression of the lateral cutaneous nerve of the thigh. During calcium and metabolism and the locomotor system. Daily requirement of calcium during pregnancy and lactation is 1 to 1.5 grams. 50% of serum calcium is iron, which is important for physiological function. Calcium absorption from intestine and kidneys are doubled due to rise in the level of 120 and 20 dihydroxy vitamin D3. Calcitonin levels increase by 20%. There is increased mobility of the pelvic joints due to softening of the ligaments, mainly by hormone. The increased lumbar lordosis during later months of pregnancy due to enlarged uterus produces backache and waddling gait. Changes in the endocrine system. Placental hormones. Placenta produces several hormones. Mainly the high levels of each of them produced by are responsible for breast changes, skin pigmentation, and uterine enlargement in the The chorionic gonadotropin is the basis for immunological pregnancy tests. Human placental life stimulates the growth of the breast. Pituitary hormones, the secretion of prolactin, adrenocorticotropic hormones, thyrotropic hormone, and melanocyte stimulating hormone increases. FSH and LH secretion is greatly inhibited by placental progesterone and estrogen. The effect of prolactin secretion are suppressed during pregnancy. Posterior pituitary gland releases oxytocin in low level frequencies throughout at term the frequency pulse and stimulates uterine contractions to facilitate delivery. Thyroid function gland increases in size by about 13% due to hyperplasia of the glandular tissue and increased vascularity. Increased uptake of iodine during pregnancy. Pregnancy can give impression of hyperthyroidism. Thyroid function is basically normal. The basal metabolic rate is increased mainly because of increased oxygen consumption by fetus and the work of the maternal heart and lungs. Any doubts? Any doubts? Any questions?